Şimdi ikinci konuşmacımız sabahleyin de çok güzel bir konuşma yapan, bu konuyla ilgili konuşma yapan Sayın Regina Beets, MR ile tam yanıtlı hastalar seçilebilir mi, belirlenebilir mi konuşmasını yapmak üzere kendisini davet ediyorum. Buyurun Beets.
Thank you very much. So my focus now is on the MRI and its role for selection of clinical complete response. Important is that we have accurate tools to assess a complete or near complete response during the time of assessment, and that's still a debate which is the best time. Also important that we have very accurate tools to follow these patients so we can detect local regrowth early on. So these patients can still be salvaged. Question whether imaging can help us, and then it's about answering the questions whether there is still tumor remnant in the bowel wall, whether all nodes are sterilized, and is there early detection of tumor regrowth. So if we look at meta-analysis of the MRI, the MR as we usually see and evaluate as radiologists, then having this image of a fibrosis, which is dark, the sensitivity is only 20%, so we miss a lot of complete response. Again, the ESCA consensus paper that shows that diffusion should be part of the restaging protocol, because diffusion has a role in identifying the ones who have not a complete response. It's very powerful in excluding a complete response. So this is already several times referred to, this paper, that endoscopy and clinical exam is still the best method, even better than only MR plus diffusion, but the combination of the four gives us the best performance. So this is the image of a clinical complete response. Very typical, white scar tissue, no diffusion signal, only a small fibrotic band. This is also an image of a complete response. There's a heavy fibrotic tissue, which is a little bit scary. If we wouldn't have the diffusion, we would not be so confident as a radiologist to call this a complete response. So we looked into our data and looked on the MR only, so without diffusion, and look at patterns. And the patterns of a clinical complete response, the majority has this stripe of fibrosis within a bowel wall that is not distorted. And up to 20% have this thick fibrosis, and sometimes you don't have any fibrosis, but that's not the majority of the patients. So the image of a sustained complete response is one which has no change in the fibrosis. Minority, the fibrosis normalized, and also in a few patients the fibrosis became thicker, but the majority of sustained complete response has no change in fibrosis. So we know that this is a complete response because it remains like that. The problem is if you have this kind of tumors that after chemoradiotherapy disappear and you have this fibrotic band, but there is still the ulcer at endoscopy. So what to do with that? Because we know that if we resect this from our historical data, 2/3 will have a complete response. But if we would not do anything, then 1/3 will grow into a local regrowth. So what can imaging help? That's the question. And if we have a tumor that has this kind of endoscopic image after chemoradiotherapy, you see that often, then if I add the MR only, this could still be one of a complete response. So it doesn't really help us. It could be a complete response, but it could also contain tumor. It doesn't really help us. And the hope is that we have diffusion that can give us more confidence in ruling out a complete response. So we thought this was indeed a residual tumor because of this high signal on diffusion, but the patient had a complete response. So we looked into this, the reason of why diffusion is so powerful, yet it doesn't always work. So we did a multi-center study, including diffusion in multiple centers, including non-teaching hospitals. So with local radiologists looking at diffusion. And we asked them to do the first reading and taught them and gave them feedback on their histological finding. So all patients got a resection, and they got feedback on their own performance after each 20 cases. And you can see that their sensitivity improves, and we found that around 60 scans is needed before a radiologist gets that optimal level in using the diffusion. We also found that the protocol is very important. A diffusion protocol is not so easy. And in our series, we found that the diffusion quality, a significant proportion, was low in quality, as opposed to the T2 weighted of the same centers. They were okay in quality. But this one is of concern. And that is because it is a poor protocol. The poor protocol causes pitfalls. And we looked into those pitfalls and found the majority of the pitfalls being caused by artifacts. And these artifacts I want to share with you. These are the artifacts that can confound the diffusion image. This is because there's air in the rectal lumen, and the air causes these strikes. It doesn't really follow the anatomical curves, so you can recognize this as an air artifact. So in the patient where we had an error, and we thought it was tumor remnant, that patient had an air bubble. And around the air bubble, these high spots occur because of an artifact. And that is the pitfall that we now know and understand because we look into the data. So we perform the MR, preferably after endoscopy, and we give a rectal enema, little enema, to the patient 15 minutes before he enters the MR unit. So we ask him to come in 15 minutes. We give him the enema, he can insert it himself, and then there's a restroom, and then he comes into our unit, and all the air has gone. That helps to get good diffusion images. Then the other artifact is the shine-through artifact. If you have this tumor, like here, after chemoradiotherapy, it changes with the fibrosis over there, right? And here, the very high signal of fluid. Now, on diffusion, you will see this signal of fluid as we call that the Mercedes-Benz sign, because you can see that this is the sign that mimics that one, which is not a residual tumor or a tumor regrowth. We also have the inflammation as a pitfall, because inflammation has a high viscosity, so a restricted movement of protons. So it mimics the high signal of malignant tumors. And if you wait a little bit longer, then inflammation heals, becomes fibrotic, and the diffusion signal disappears. So that is the test of time. If we have an ulcer, we doubt about the signal, then we wait 1 month and we reassess, and the image completely changes, and sometimes into that of an obvious clinical complete response. So 2 examples where we put all the information together. Here a patient after chemoradiotherapy with an ulcer, and here a dubious signal on diffusion. So we reassess after 1 month, and the signal disappear, and the ulcer becomes a white scar tissue. So the patient is followed. At 6 months, you don't see anything. At 11 months, a signal all of a sudden is shown here on diffusion. A little bit edema, but nothing worrying. And then you continue follow-up, and you see that at 22 months, the signal is growing, but here the endoscopy shows the regrowth. So here I can say that we were very, very fast in detecting something growing within the wall. Here's another case, more recent case, where you have this after chemoradiotherapy, the edema, and then also the fibrosis corresponding to white scar tissue. At 18 months, you see this image of fibrosis over here, and again the Mercedes-Benz sign, so that is just shining through of the lumen. But then here is something. So what is that? Is that regrowth? We continue follow-up. You can see here fluid of the lumen, fluid shine through, but then this is still a remarkable signal. And at 25 months, you were convinced it is an endoscopic proven regrowth. And as you can see here, here's the Mercedes-Benz sign, but there is obvious growing signal. So this was at 18 months already a sign of a regrowth, which you don't see here on the endoscopic image. Diffusion in general hands, it helps to assess the complete response. This is from our trial, an improvement in sensitivity and an improvement in negative predictive value, especially an increase in confidence with a reduction in number of equivocal scores. Also, the diffusion has value in the detection of tumor regrowth with an improvement in sensitivity and a reduction in number of equivocal scores for regrowth. Now the nodes, how to deal with that? Primary nodal staging is not so accurate. Nodal restaging is different, and especially in a complete response follow-up setting, we are not bad, because it's not more than just following the anatomical growth of a nodal deposit. So it's not so difficult as primary staging. The impact is less significant. We found in historical data that radiologists were good in identifying node positivity in an irradiated mesorectum. And that is because the mesorectum is easy to interpret after chemoradiotherapy. The majority of the nodes disappear, and many become smaller, so it is a mesorectum which is more empty with only small nodes. So if we see this node that is very suspicious initially, and after chemoradiotherapy the node is 5 millimeter or higher, then there is a certain risk, there is a significant risk for node-positive disease. So in the guidelines we have now included that if we see 5 millimeter nodes or larger on post-chemoradiotherapy MRI, we will consider this as node-positive disease. But in the follow-up, we can just look at the subsequent images, and we look at where the nodes are. And in this series, we found that the majority of the persistent positive nodes were at the tumor bed level and higher, and the majority also at the side of the tumor bed. And this has also been published recently, where we looked at the diffusion, the role of diffusion for nodes. Diffusion cannot distinguish benign from malignant nodes, but it can tell us the node negatives. Because if I look at the diffusion, I see all nodes, and in one glance, I look at the post-chemoradiotherapy, and I don't see any nodes. That is predictive of node-negative disease. So all this little information, it helps us. Now, I've focused on this much in my first lecture, but this is the future. Are we going to predict response? I hope we can do that for you, to select the patients who will completely respond, or maybe even better, to select the non-responding patient. And we will do that with multiparametric imaging. I've already shown you this, the perfusion image that is promising. But this is a series that we are now working on, the pre-treatment ADC maps. If we looked at its performance to predict complete response after chemoradiotherapy, as you can see, not very good. PET on itself, we looked at the performance of SUV, also not so good. But if we combine the data, then you can see that the area under the RAW curve can improve. So at the moment, for organ preservation, I think there is a role for us in the selection and in the follow-up, but the role is not the central role. We can help you and give additional information and confidence in your selection. And it's going to be the 4 combined. So as a radiologist, I always take into consideration also the endoscopic report and the images, and we open them on our workstation as well. And for MRI, the role, of course, is important to identify nodal regrowth, and I think it's sufficient to just make consecutive images and follow the notes. Thank you.